Okay, resume recording. We're all the instructors are working from home, and we're trying to get access to all the computer stuff at work, and so we're in the process of doing that. So if you get a delay in your email answers to your emails, that's why we're trying to get all this technology stuff connected. Again, if you're here, type your name in the chat so we know, so we can give you credit for being here. So today we were going to go over, I'm going to hit share screen here. Let's see, it doesn't have. Well, Lori?
Yes.
I can't get, maybe if I exit full screen, maybe that'll, oh, there we go. Okay. Okay, let me, I had this all set up and now I'm, Karen, there we are. Okay, now how do I get back to my Zoom meeting? There we go. Share screen. Everybody see that?
Yes.
Yep. All right. Cardio-respiratory.
Sorry, I did.
It was
All right, respiratory system. We breathe in through our mouth and nose, goes down into the larynx, the trachea, bronchioles, bronchi, into the bronchioles, and down into the alveoli. Have three lobes on the right, 2 on the left, because your heart lays right in here. So, all right. Trachea goes into the primary bronchioles, or primary bronchi, secondary bronchi out into each lobe, and then tertiary bronchi out into the bronchioles. You guys should all have that in anatomy physiology if you haven't yet. But anyway, at the end of the bronchioles are little alveoli, little air sacs, and that's where the capillaries, that's where the air exchange, oxygen exchange is. Let's see. Lungs send out oxygen to the red cells. I'm reading as I'm going here. This is a new slide for me. Basically, the air goes into the lungs, goes out into the alveoli. There's oxygen's exchanged to the red blood cells, transferred out to the organs. The organs send carbon dioxide back to the heart and the lungs to get reoxygenated. Our lungs are lined with the pleural membrane, the pleural space, and there's the parietal as well too. But anyway, our our lungs are lined, so when we breathe in and out, it slides well on the chest wall. There's serous fluid in between the membranes, so that makes everything nice and lubricated to where it works. When you're assessing breath sounds, you want to know what the rate is. This is how you document it. You document the rate, the depth, whether it's shallow or deep, the rhythm, whether it's regular or irregular, and any character sounds that you can hear, like audible wheezes, whether they're labored, they're using accessory muscles to breathe, anything like that. When you're taking when you're counting the respirations, you don't let them know that you're doing that because they'll change their breathing pattern. So I do it when I'm checking the radial pulse, and I just continue to look at my watch like that, and that way they don't know that I'm taking their respirations. This is all the pathophysiology of breathing. When our diaphragm contracts, it draws air in. When it relaxes, it pushes the air back out. Pretty basic. The normal breaths per minute is 12 to 20 for an adult. Little vocabulary. Eupnea is normal rate and depth of breathing, easy respirations with rate that's age appropriate. Tachypnea is abnormal increase in breathing greater than 24 breaths a minute. Bradypnea is decreased in breathing less than 10 breaths a minute. Apnea means that there's no breath, no breathing at all for several seconds. If it lasts very long, then it goes into respiratory arrest. So when you're assessing the lung sounds, you want to make sure you're not over the bones. Go in between you can see the scapula here on either side. You want to make sure you're on the inside of that, and you're not over the ribs. You want to be on the intercostal spaces. So you want at least 6 spots. This one here has 10, and this one has 12. You want to make sure you listen to all the lobes, and so that's why you do so many there. Alternate back and forth. You can see how it kind of zigzags when you do that, or when you listen to the breath sounds. You go in that pattern. Also, you visualize the chest and the back, the thorax. When they're breathing in and out, make sure both sides are expanding the same. If you have a collapsed lung, one won't move and the other one will. So that's a very good, useful tool to use. You observe the shape and make sure everything is symmetrical. All right. Adventitious lung sounds. Crackles, they're a bubbling or rattling sound. It's usually you have fluid in the lungs. It's usually like if you have, when you start getting pulmonary edema, CHF patients have that. Fine crackles, you have to have a really good stethoscope to hear those most of the time.
Dan?
Yes.
Do you want me to record this?
I'm recording it. If you help me download it later, that would be awesome. Hey, it says Deborah Ruff on there. That's not you.
Surprise.
I'd rather not record it, but they told me I had to, so.
Okay, so you're recording it to your computer?
Yeah, I'm recording it. Oh, there's somebody trying to get on. There we go. If you want to jump in here and say anything, feel free to jump on anytime. If you have inserts, just holler. Speak up. Let's see, rhonchi. They're more of a snoring sound. That's in the larger airways when they get restricted and fill up with mucus. Wheezing is a high-pitched sound from the bronchial tubes when they get, it's down in here, when they get, they have a lot more muscle and they're a lot more elastic, so they can expand and contract a lot more than like the trachea here or the large bronchi here. So when you hear wheezing, it's usually from these tightening up or filling up with mucus. Stridor is usually a high-pitched, real high squeak, and that's usually up in here when this airway is blocked up here. Not a good sound to hear. Lung inspection, talked about this a little bit. Look to make sure that the expansion is equal. There's no, like sometimes you'll have an arch in the back here on the top, that's kyphosis. Sometimes it'll be, it'll have a little curvature to the side, that's scoliosis. Sometimes you get a little divot in the chest like this, and I don't know what the name of that is, but I'd have to look it up because I haven't done it for 4 years. Barrel chested. This develops when the air in the chest isn't expelled adequately and it gets trapped and it increases the size of the chest wall because it can't relax back down. See how the diaphragm's flat here? It should have a nice curve on the x-ray here. It should come down and have a point down here on either end. And kind of, it's hard to explain there. Anyway, you can see how the shape of the chest is barrel shaped instead of being more flat. Positioning, if somebody's having a hard time breathing, sometimes it's easier for them to breathe if we call it tripoding, where they rest their arms on something like their legs like this or the table. It just helps them to breathe a little bit easier. Not sure the mechanics of it, but I know it works. I've watched it a lot. Use of accessory muscles. When you start seeing when they take a deep breath in, you get, it's usually people that have really poor respiratory status. They're having a hard time getting their breath in. It takes a lot of energy to breathe. So they get really skinny like this because it does take a lot of calories. And a lot of times they just don't feel like eating. They're concentrating more on just breathing than even eating. So they lose weight and it looks a lot like that. Cardiac system review. Anybody not know this part? high school circulation. This is the left ventricle. It goes out the aortic valve right here, out the aorta, up to the head. This goes down to the body, over to the liver, digestive system, down to your legs. Inferior vena cava comes back up to the heart. Superior vena cava comes down from both lungs, comes into the right ventricle, or the IVC comes into and SVC come into the right ventricle. This is the pulmonary artery. I know it's blue, but it's still an artery. Arteries take blood away from the heart and veins return it. So this is the pulmonary artery, goes out to the lungs, gets oxygenated, comes back, goes out to the body. All right. It's blue because there's no oxygen in it yet. It's going out to the lungs to get oxygenated. We talked about that. Each side has an atrium and a ventricle. Just a little information. If you're in AFib and the top part of your lungs, or top part of your the atrium of your heart are in fibrillation, they're not really working real well. You lose about between 20 and 30% of your cardiac output. So it's really important for you to be in sinus rhythm. Anyway.
Can I interrupt again?
I didn't hear that.
Can I interrupt again?
Certainly.
Could all of the students get into the chat and then put the hour 9 and then put your name to make sure that we get the roll for attendance at this meeting?
Yeah, they should all have entered their name into the chat. Let's see. I don't see the chat thing. I got 49 participants. I just don't see my chat.
Because you're sharing your screen. If you exit your share screen, you're able to see the chat.
Oh, I don't want to do that yet.
I also have taken a roll, so.
Okay, awesome. Thank you. Did you want to share anything on the slide there, Karen?
All I was going to say is what I talk about when we do cardio and bio and stuff is that all exchange, I don't know if you've already said this, all exchange happens in the capillaries. You have arteries and arterioles are smaller and capillaries. You have veins and venules are smaller and capillaries. So
it's really hard for me to hear Karen. I don't know if anyone's having the same problem.
Yeah,
It's hard to hear.
Yeah.
I can't hear a thing either.
Is it just me or is Karen hard to hear?
Karen, it's hard to hear.
Okay.
Yeah, I can't hear her either.
What she was saying was that the oxygen exchange happens in the capillary, oxygen and nutrients and everything. All that exchange happens in the capillary beds. You have arteries, arterioles, and then capillaries, and then I can't say the word, venules and veins. It just gets bigger, or it goes from big to small back to big. And that's in the capillaries, the real small, the really thin wall. That's how you get bruises. Is you get hit on the arm, and it breaks those little capillaries, and so you bleed out into the tissue. And that's where all the exchange of oxygen and nutrients and electrolytes and everything occurs. That's what Karen was trying to. All right. Heart sounds. Best to have them elevated 30 to 45 degrees or upright. If they're flat, it's harder to hear because you have all the belly contents pushing against the heart, and it kind of muffles it a little bit. You notice this guy isn't wearing a shirt or anything. That's because if you have clothing on, it muffles the sound. So try to be right on the skin if at all possible. Normal heartbeats are 60 to 100. The normal sound is a lub-dub sound. That's the S1 and S2. Rhythm should be regular. With breathing, sometimes it speeds up and slows down, and that's normal, but it shouldn't be really irregular.
So I have a question, Dan.
Okay.
So it's easy for a guy to take off his shirt so we can do the sound without no barrier. But when it comes to the female, then what? We're not going to tell the patient, hey, you need to remove your shirt so we can listen to the sound. Because I mean, as a patient, I have never had that happen. They just do it over my clothes all the time. So
That's-
what, at that point, what, I mean,
Depends on what extent you're trying to examine the heart. If you're listening for rubs and, you know, the little intricate sounds, you'd want to be right on the skin. If you can hear the lub dub from, like if they have a t-shirt on or something like that, if you're just listening for the heartbeat, it's okay to do it over the shirt. But if you're listening for any valve clicks or sounds or anything like that, rubs, anything like that, you really need to be right on the skin. A lot of times I ask the patient, if they're alert and oriented, they can put it down underneath their shirt, and I've done that. A lot of times the women don't care. They just pull their shirt off and let you listen. But I've never really had any problem. There's always a way you can adapt. If they really don't want to, I've had guys that don't want to take their shirt off too. So yeah, just if they'll let you, just put it down inside their shirt and then hold your finger on it. It's a good time to talk to your patient. Ask them how it'd be the best way to do it. They usually, if they're able to talk to you, they'll talk to you and let you know. Does that help?
yes, thank you.
Okay. And again, it just depends on how precise and accurate you want to be. If it's a cardiac patient and you really need to hear the sounds, all the sounds of the heart, you'd want to be right up on the skin. All righty. S1 is when the tricuspid and mitral valves close. S2 is when the aortic and pulmonic valves close. Heart valves. Pulmonic. Let's see. I'm not familiar with this one. You want to jump in there, Karen?
So like you're talking about mitral and
Where you're going to hear
where you're going to hear your mitral versus
Yes.
mitral. So the way I do it.
Mitral is usually down here. The aortic valve is up higher.
Apical. Number 4 is your apical.
Yes.
Yeah, or mitral.
So
This is tricuspid.
uh-huh.
What is it?
All positions.
Pulmonic.
All positions take money.
That's right.
Aortic, pulmonic, tricuspid, and mitral.
That one's apical, yeah. We just
This is for the mitral valve as well.
Yeah. The
Same
apex
spot.
is actually lower than the one.
Yeah, right there at the apex. We just call it apical because it's at the apex, but
Yeah,
that's
it's apical is fifth intercostal. Apical is fifth intercostal mid-axillary, so it'd be right in here. Yeah.
right. I would think that was where the 4 should be, but that's okay.
I was trying to think of the mnemonic.
Let's see.
My mnemonic is MTAP.
Oh, that's right.
That's right.
MTAP? Are you going backwards?
MTAP, yep.
It's just if you're listening for the apical pulse, you're really looking for that
MTAP,
pulse of maximum impulse. You're not listening to valves that are at the apex.
No. Yeah. Let's see. That's apical pulse. Again, it's midclavicular fifth intercostal space. That's important. You'll want to know that spot when it comes to when you get into third term doing EKGs. That's where the your V4 lead goes. Anyway, you'll learn more about that.
I have a question.
Yes.
Are these PowerPoint, is that going to be uploaded to my IoT?
I can do that.
That would be great. Thank you.
Okay. I usually draw this on the board. When you're usually when the pressure in the veins are low and the pressure in the tissue is high, the fluid flows from the tissue into the veins. But when you get heart failure and the pressure goes up, then the exchange can't happen. And so that's what develops the edema in the feet. And so it collects down here. That's edema. We would call that, if that stays, that would be called pitting edema. I think we're going to cover that further. So purple or discoloration of the skin. Sometimes the skin will feel cold to touch and moist, cold and clammy, we call it. If somebody's having a heart attack and they look like that, you better start doing CPR on them. Time to get to business. A lot of wounds like this are due to insufficient blood flow, and so if you don't have enough blood flow down here, you don't get the nutrients or the oxygen, and you'll develop vascular sores there. That's called vascular insufficiency. That's what that was all about there. Okay. So edema, that's when fluids, this is called pitting edema. That's when you push down on the tissue and it leaves an indentation like this. Just meaning that the fluid in the interstitial space can't go into the vascular space, so it collects down there. The severity we grade on a 0 to 4 plus. This is kind of the scale here. There's a couple, 3 different scales, so don't chisel one into granite. There's lots of different ways of doing it. Just get to know what scale your facility uses, so everybody's doing the same thing.
Can I interject?
Yes.
One of the things, because the heart is that two-sided pump where you have deoxygenated blood coming into the heart and going through the right atria and the right ventricle, and then it goes up to the lungs to get oxygenated. That right side of the heart, if you have right-sided heart failure, what you're going to see is like a traffic backup. If it's not pushing everything out the way it should push it out, it's like the blood is backing up, so the fluid collects, and you can see there's edema in the lower half, usually just like this. You'll see the legs and the feet, and you can see that right-sided heart failure. Correct, Dan?
Yes, correct.
And then it goes up to the lungs and then comes back to the left side of the heart, to the left atria and the left ventricle. But if that backs up, where are we going to find signs and symptoms of left-sided heart failure?
Erin, wouldn't that be in the lungs that you would hear the backup?
Absolutely. That would be right from in the lungs that you would hear that backup. So you would hear fluid in the lungs. You may hear some crackles. So that two-sided pump, the way that it works and the signs that you see can give you clues to which side of the heart. Is there a possibility there's two sides of the heart failure?
Yeah.
Absolutely. Absolutely.
I was second guessing myself there.
No,
there can be, yeah.
Yeah, so you can have two, complete heart failure where, what is it, Dan, your ejection fraction is less than 30, and so things just are backing up everywhere.
Yeah.
And So, and they will soon be overcome with fluid in the lungs and edema.
So how do a question for you? If they're not on the Zoom call and you have to document that you have that you've watched this, what is a sign or symptom of pulmonary edema, left-sided heart failure? That would be pink frothy sputum because the fluid is going, there's so much pressure there that it's pushing it through the capillary bed into the airways, into the alveoli, and filling up your lungs with fluid, and you're trying to breathe there, so it's when you breathe in and out, it causes this pink frothy sputum.
Yeah, because all exchange happens in the capillaries and they're leaky, so it does.
Oh, I didn't even know that.
So
this is the person that when they show up in the emergency room, this is a dire emergency. This is the guy that's going to be in that tripod position. He's going to want his feet dangling. He's going to need to be on a high flow oxygen mask, and you're going to be getting IVs into him and getting diuretics into him. And yeah, he is in very acute danger.
Yeah, lots of Lasix. Compression stockings a lot of times. Things that we can actually do. You have to have a doctor's order, but you put compression stockings. One thing that we don't have to have a doctor's order for is elevation of the feet. If you elevate the feet, that helps gravity bring a lot of the fluid out of the tissue back into the vascular space and to where the body can eliminate it through the kidneys.
Is there any time that you would not want to elevate somebody's feet?
If they have a pulmonary embolus, I wouldn't. If they have a DVT, pulmonary embolus, you don't put on compression stockings, you don't rub their legs, you don't elevate their feet because the flow is going to come back to the heart and just helps get that clot back to the heart, and you don't want that to go there. You want to leave it dependent so they can dissolve it with medication. But usually you'd want to elevate the feet to get all that back. Cap refill, that's how we kind of check the circulation in the extremities. So how we document that, it's greater or less than 3 seconds. There's not a 1 or 2 or 3. It's just greater than or less than 3 seconds. When you press down on the nail bed, it'll turn white, and when you release, you count 1001, 1002, 1003. If it comes back before you're to 1003, it's less than 3 seconds. If it comes back after you've hit the 1003, it's greater than. It's pretty simple that way. You want to do that on the fingers and the toes as well. You want to check cap refill in both places. Jugular vein distension. I got one for Karen. Which side of the which I know she knows this. So
oh, on the spot. Don't say that.
But jugular vein distension, which sided heart failure would you see that in?
Jugular vein distension would be, so it's going up and then through. It would be, I haven't been asked this before, so I have to think it. Because it's going up through. That would be right-sided?
Right here.
Oh, it's right there. I didn't look.
I know.
It's right-sided, right?
Yes.
Yes.
That's what causes the.
Right.
This is when the pressure gets it gets so high in the veins that it gets up in here and up into the jugular vein. Now you set somebody up and you measure that from here up, and you'll count so many centimeter jugular vein distension.
And this is because we have the inferior and the superior really large vessel called the vena cava that empties the blood from the top half of the body and the bottom half of the body into the heart. And so this is telling you the right side is not pumping out fast enough for the body to empty that blood into the right side. So that's the backup. Not only does it happen in the legs, but it happens up top because it's still the right side trying to get the blood through the heart. Yes?
Yep, the pump isn't working.
That pump isn't working. Cool, thanks.
Thanks for interjecting. I like the help. Oh, why would we cover that? You can't see it yet. Why would you not? This is another question for those that are watching this on the recording to answer. Why would the hair follicles, why would it make a difference whether the hair follicles, there's hair on the legs on a patient with heart failure? The answer to that is they're not getting nutrients to the hair follicles, and so the hair falls out, and it gets also the swelling. There's really no space for it. It gets so tight and so full in here that it just everything just fills up with water. So that's what makes the hair disappear.
An interjection on this: what is a condition that your patient might have that might add to this issue of heart failure and then having wounds on legs that won't heal?
Diabetes?
Diabetes, absolutely.
Yeah, venous
Nice job,
insufficiency.
Megan, Karen. Nice job.
Another thing, you notice on one leg, it looks fairly normal. The other leg, it's swollen. This is a sign of a deep vein thrombosis. When one leg swells like this and the other one doesn't, the doctor, if it's new, the doctor would start checking to see if they have a DVT there. That's why sometimes in nursing homes you'll have to measure the legs on people. I've had a few people like that, and the reason being is because they've had a DVT and they're wanting to see if it's getting better or worse.
That was called peripheral artery disease, or PAD. When you hear that, you'll know what that means, and you can look for it when you go to the grocery store and you're looking at people's legs.
That's what happens with it. That's what happens with this.
PAD, yep, it sure does. It's super awful.
Yeah. Or a shorter term is vascular insufficiency.
Okay.
PAD is more specific. It tells you the physiological. It tells you it's the artery instead of the vein.
Yeah, absolutely.
On this one, this would be venous insufficiency, because you're starting to see the swelling and the redness, that sort of thing. If they're white, like the other one, that's arterial insufficiency. If they're red, it's venous insufficiency.
Dan talked briefly about compression earlier for people who have this kind of edema, but you do need to know specifically, is it arterial or is it venous? Because you do not compress an arterial insufficiency.
Right. That would be back here. Oops. That would be like that. Usually you don't have edema with arterial insufficiency. It'll be normal looking like this except for the wound. The venous insufficiency usually have the edema.
So Dan, I have a question.
Oops. Yeah.
So with a wound like that on a PAD or a DVT, would you put compression stockings on that leg even if it has a wound on it?
On the PAD one?
Right.
No.
Okay.
That's what Laurie was just saying. You don't ever put compression stockings on and if you think of it, you're wanting the flow to come down. If you put that compression stocking on there, it's going to reduce the arterial flow down to the feet, and you don't want to do that.
Right.
That's the mechanics of it. Yeah.
There are tests that will be done to determine one way or the other generally. So if it's determined to be a venous insufficiency and they're able to put compression on, then they would probably use a compression dressing wrap until they're healed and then put them into like a compression stocking.
Yeah, that's what we used to do at the wound care center that I worked at.
On the arterial, you just do like a gauze wrap with whatever your wound care nurse tells you to put on there.
Mm-hmm.
Or whatever the doctor orders.
Let's see. Symptoms of a heart attack. That's the chronic sign there. Somebody putting their hand over their heart like that. And that expression. Sometimes it will radiate up into the neck, up into the jaw. Sometimes it'll go down to the left arm. Feel like an elephant sitting on your chest. Some people get nauseated with it. Their skin will be, like I was showing you on that one before, very diaphoretic. They'll be sweating. They'll be pale. Skin's cool and clammy. Sometimes the brain gets confused. So instead of getting chest pain, you'll get nausea and vomiting, and you'll get epigastric pain. It'll actually be down here in the belly. You always want to make sure that you have to take them into the hospital and make sure that they have ways of differentiating that out into whether it's epigastric or cardiac pain. Shortness of breath, decreased ability to return the blood to the lungs for reoxygenation. If your heart's not working, it causes your cells to be deprived of oxygen, and your brain kicks in and says, tries to breathe harder, but then you can't because it's not getting oxygen either. Sweating, lightheadedness, symptoms of cardiogenic shock. Just the definition of shock is when your blood pressure drops so low that you are not functional. Is basically, there's a number, but it's usually more. You see the signs and symptoms. You start getting sweaty and you get pale and your oxygen saturation drops and your blood pressure drops, that sort of thing. Okay, yeah, so the lightheadedness and the sweating is from the reduced oxygen to the brain. So if we have a doctor's order, we put compression on there. Elevation, we do that just to help gravity. Again, with diuretics, the number one diuretic is Lasix. And we'll talk about that on the, maybe we'll talk about that on VSIM, but heart contractility medications, those of you that are in pharmacology, I don't know if you talked about beta blockers or not, that and digoxin, beta blockers, those types of things help the heart contract better and help the, as you can see here, this is the electrical activity of the heart, or the pathways. The digoxin and amiodarone, those types of things help with problems in the conductivity. Oops, that can't be the last one, can it?
Yeah, that's the last one.
Okay. So, this one here is the same thing, isn't it? This PowerPoint, I think it's the same thing.
I don't know what you're talking about at the moment.
You can't see me here?
I can see you, but I don't have another PowerPoint up. There is another one that was heart and respiratory, but it covers the same stuff we just talked about.
Yeah, the sim day for term 1 students.
Yeah, that's just covers the same stuff we just talked about.
Ah, how come it's not letting me? It's on my screen, but it's not letting me share it for some reason.
Okay, we don't need to do it anyway. We already did ours.
Okay.
Do you have the postmortem one available?
I do. Karen sent it to me, so I will bring that one up. Into life care.
Yeah.
All right, here we go. I got to get into the Zoom. Share screen. Okay, come on, share the screen. Technology is fun if you know how to use it. All right. Where's the, oh, there it is. So you can see the bigger version of this. All right, end of life care. Impending death. There's no way to predict how long a client will be stay alive. I've had patients that I thought would die overnight that got him walked out of the hospital the next morning. And I've had people that came in just as normal as could be that died that night. So it's hard to tell. It's hard to tell how long a patient's going to be around. Oops. They may have signs of impending death. Their respiration slowed down. Their heart isn't circulating very well, so they get pale and that. But then they can have an event. You know, family comes in and says something or whatever, and they rally back and they can stay alive for a lot longer. Well, let me get rid of that. Okay. One of the nursing another question for those that are watching the recording. One of the is what is one of the duties of the nurse with death and dying? The answer to that would be prepare the family, talk to them and communicate with them, let them know what's going on. Never ever easy with family, even if they've been expecting it for a long time. It's never easy. We need to inform them about what's going to happen. You know, the stages leading up to their death. Also, give them information on what they have, what they need to do after the death. Most facilities have a packet that they'll give to the family, and you can just go over that packet. It gives them a checklist on what the things that they need to do after their family member dies. Impending death signals. You don't get good gas exchange. Change Stokes breathing. Real rapid breathing with periods of where they completely stop breathing. The heart and the blood vessels don't have adequate perfusion. If the brain doesn't have oxygen and nutrients, it starts shutting down. So patients can get confused. They get lethargic. They don't respond to sensations. One of the things that we used to check for is what's the pain, Karen? Or Karen or Lori, when you pinch the nail bed.
The turgor? Oh,
No.
when you pinch the nail bed.
About the,
Sorry.
Anyway,
one of the
you pinch the finger and the pain response, and you pinch the finger and they don't do anything. There's a word for it, but I can't think of it right now.
So Dan,
Oh.
when patients are marbling, is that basically like the blood flow is stopping, is like ceasing to those areas of the body?
Yeah, it's reduced circulation. Yeah, I think it goes into that a little further down. So when we know that the patient's going to die, it isn't a chance for us to go do other things like take breaks and that sort of thing. We still have to care for those patients, right? So main thing is keep them clean, warm, and dry. Make sure their comfort needs are all taken care of. Don't like to see pressure ulcers develop on hospice care patients. So we still have to turn them, we still have to bathe them, that sort of thing. Hearing is the last to go. Encourage family to talk to their loved ones. Most of the time, I would say almost always, until they completely die, they can still hear. That's the very last thing to go. A lot of stories about that. 15 years later, I got told something that I'd said, to a patient 15 years earlier. I thought that they were gone. But anyway, yeah, hearing's the last thing to go. So don't say crazy things.
Did you say something bad?
No, it was just, I was talking the doctor through the procedure, and we thought the patient had died, and I said that we probably need to hook him up to a pacemaker or something or the external pacemaker or something, because we didn't have the leads down in the heart yet, and we shocked him and he came out of it, so it was all right. But he came back 15 years later and said, you're the one that was talking to the doctor through the procedure. I go, oh, embarrassing. The doctor was very competent. It was just his first time, so it was a sequence thing that he knew what he was doing. He just had to be reminded of the sequences. But anyway, 15 years later, the patient came back and told me that. Anyway, after the patient dies, we still have to take care of them, right? Clean them up before they move the body to the morgue or the mortuary.
As a CNA in the hospital, it was part of my job to go down to the morgue, because in ICU or the ED, they do not remove any of the tubes. And so it was my job to go down there and clean the body to get it ready to go to the mortuary.
Yeah, there's, depending on, you don't always remove everything depending on how long the patient's been there. If they have to be, if the coroner has to examine the body, you leave everything intact. And then after you get the all clear, then somebody can go down and take all that out. But yeah, that's the reason for that. Sometimes the coroner has to come in and take a look at the body. Mm-hmm.
When you see a big green box going down the hall, you know what's gonna go down.
Yeah.
Beth knows what I'm talking about.
Yeah, we had one at Salem and Kaiser Hospital up in Portland. We had a frame that covered it, so it was just a big, it looked like a big frame going down the hallway. You couldn't tell what it was unless you knew. But
hospital in Corvallis, we had just a gurney that had a white thing that would cover the gurney. So it was pretty obvious what it was, but in the event that it was a baby that had passed, we would put it, there was a big, large toolbox that we would put the baby in to move it down to the morgue.
Lots of different ways of doing that, right?
So I have a question, because this happened one time when I was a CNA at Riverbend. So we had a patient that she was pretty much dying, but she had a pacemaker. So the family pretty much like was ready to let go, but the patient wouldn't die because the pacemaker was keeping her alive. So at that point, I mean, I know we still care for them, but then at that point, I mean, exactly what do, I guess, like, what do we do? Because I know the family was really frustrated because they're like, she's gone and her heart is pumping because the pacemaker is keeping her alive.
But then in that situation, the doctor would have to write an order to shut off the pacemaker.
Which it took, I think, took 3 days for someone to finally come up and turn off the pacemaker.
Yeah, sometimes it does. Not ideal, but that's just one of the processes of, sometimes it's hard to get the doctor to respond, and then once they respond, you have to get a hold of the pacemaker company, and then they have to send out a rep to shut it off. So
the pacemaker itself, though, is only sending out a signal. It's an electrical signal, but if the heart tissue is dead, it will not respond. So she must have had enough live tissue for it to work if it was continuing to pump.
You know,
does that make sense?
Yes, it does.
The electrical flow of her heart was not sufficient to keep her alive unless the pacemaker was, like if pacemaker dependent patients, if they're up and walking around, yeah. All right.
I have a question. I was curious, so I'm a medical assistant, so I haven't really been exposed to death or postmortem care. So how do you deal with that, like, mentally and emotionally for the first time or the first few times?
Tequila! Just kidding. Support.
You take a deep breath in and stay professional while you're doing your job with the family and the patient. And then when I worked in oncology, we had this utility room down at the end of the hall in our unit, and it had those great big rolls of toilet paper. And so every once in a while, you'd see 3 or 4 of us in there winding off rolls of toilet paper, or big chunks of toilet paper, and crying our eyes out. And yeah, you find ways of coping. People
and
around
also,
you.
oh, sorry. I also just was going to pipe in here. I have been a home health and hospice nursing assistant for 4 years now. And my work actually offers, like therapy, and I believe we get like 15 sessions a year. So, that's also another way to, just deal with, that stage of, life.
I think you also have to think of, at what part were they at when they passed away, because I've had to take care of people who have passed away, but they were also on oncology and they had been fighting a specific cancer for however long. And it's also a matter of, like, they're at peace now and they're not hurting. And at one point you're just like, I'm grateful that they're not hurting, but obviously you're still upset about it.
Yeah.
I mostly found working in the emergency room, of course, I didn't have that same closeness to the person because I would see them on a short-term basis. So I'm sure someone who works with someone for a long period of time develops a much greater association with the person, with the family, and all of that. So when I worked med surg or ER, for me, I didn't get so bound up in it, I guess. I found it very sad for the families, especially losing children. That was more difficult. But compared to being a family member, when I lost my mom, that was very different from when I was a nurse. So you see it on different sides, I guess. As a family member, it was more impactful. And, you know, it kind of surprised me a little bit, I guess, how I felt differently. Having been associated with the medical field for so many years, but it still was different being a family member.
I also feel like, Crystal, too, that if, you know, you can ask about, you know, what are some really good things to do, but what really matters is what's going to be best for you in that sad time. You know what I mean?
Mm-hmm.
Yeah, you have to find ways to cope. My little story on that is I got reassigned to another floor and only had one patient, and that should have been a red flag to me, but wasn't paying attention to the name. I was just taking a report on that. And I went in to see the patient, and it was somebody that I'd known for 25 years. I'd worked with this gal for 25 years. The issue is she had been on BiPAP for probably 3 or 4 days, and there wasn't any possibility of her getting better, so they were going to disconnect her from the BiPAP. And so I got elected to be the nurse that gave the Versed to relieve the anxiety of air hunger. And so we had to wait until the family got there. And so after all the family got there, I went in and gave the medication. It didn't knock her out. It just, you know, she was still talking to us and everything, but she didn't experience the air hunger when we took the mask off. She lasted about 10 minutes talking to her family and that, but that messed me up for several weeks. I had to reevaluate my stand on that sort of thing quite often. But a nice thing about it is a lot of times you have coworkers that can talk to you about, you know, especially when I was working in oncology, a lot of them had been through it already, and they gave me ideas on how to cope with things like that. Had a lot of patients die, oncology patients, when I was working in there for 5 years. And so the main thing is to use your support team around you, your fellow nurses and the support team in the hospital. And a lot of times, even the family members are a support to you. They'll surround you and give you hugs, and you're stuck there for hours sometimes. So just utilize your team that you have. All righty, physiological changes after death. I'm gonna start crying if I keep talking about that one. Still bothers me.
Can I interject for just 1 sec?
Certainly.
One of the things that you might consider also is that a lot of times before death, like Dan was talking about, there's that air hunger and things like that. And so the nurse may come in and give a medication that allows the patient to relax and to die. And the family member will have said, please give my dad something, please give my mom something to that effect. And then they pass because now they're relaxed, and now the family may feel guilt thinking that they killed or caused the death of the individual.
Mm-hmm.
And we need to make sure that we reassure them that that is not the case.
Exactly.
That is exactly what happened to my mom with my grandma. And the hospice nurse came out, and she was like, I'm going to go ahead and take off the oxygen machine because your mom's gone. And she's like, but before I do that, I just need to let you know that I'm going to give her a dose of Ativan. and morphine. And then my grandma shortly passed after that, and my mom felt guilty. Like she had OD'd her mom.
Yeah, no, it doesn't. They would have died anyway.
Yep.
They're just making them comfortable. Yeah.
One
It's
thing
just
that I've seen a lot is that the family will be around their family member who's actively passing, and they'll be tired, they'll be hungry, they'll go home to sleep or go home to eat, and as soon as everybody leaves, then they'll pass at it. But generally, that patient doesn't want to go in front of their family. They want to wait until they're alone. They don't want to do that to their family. So
Right.
if you come across that and the family feels guilty because they weren't there, you just got to let them know that this is fairly common. They generally pass when they're alone. They don't like to pass in front of their family members.
That's a good point. That's very true.
Another thing that's really important is like sometimes the way that the families grieve is by caring for their loved ones during that stage. So always allow that to happen. Like if they want to do like a sponge bath, do it. Because I had a situation with my brother, and I didn't know if he was gonna make it, and I had to fight the nurses to allow me to care for my brother. And I just explained to them that was my form of grieving. Like I didn't know if my brother was gonna make it. So it's always really important. I mean, working in the healthcare and having to experience that is the most hard thing, because as a caregiver, you know what to do. As a family member, and it's your loved one there, you don't know. You don't know what to do, and you feel like I should know what to do because I do this for a living. But it's always okay to like allow them to help, because it gives them some sort of comfort. And the first patient that passes under your care, you will always remember them, because I remember the first person that passed away, and she passed away in my arms while I was changing her. And till this day, I remember it, and I had a lot of guilt, saying if I wouldn't have touched her, if I wouldn't have repositioned her, she wouldn't have passed away. But then it took me a while to realize that it was time for her to go. It was nothing I did wrong. It was time for her to go. So venting, crying it out when it happens, taking a moment after it happened and letting it out is like something that will help you along the way.
The other side of that is that after a family member passes, the family, they may scream at you, they may curse at you, they may tell you that it's your fault. They're grieving, they're hurt, they're upset. Don't take it personal. Do not blame yourself because nature happened. Even if the family is screaming at you about it, that's their way of grieving, because they don't know what else to do. They are overcome by emotions they haven't felt before.
Good point.
Never take it personally. I've been in the middle of fist fights after patients have died, so yeah, don't take it personally. I wasn't fist fighting. I was just in the middle of it. I was trying to break it up.
To stop it.
I just tried to keep them apart. But yeah, lots of different aspects there. You just, again, you want to just utilize your resources around you, your team, get help. There's going to be times when it might be one of your favorite patients and you're really close to them and you can't, it's really emotional for you to do that. You might want to trade assignments, something like that. Just work with your team. That's the best way to deal with those things. Alrighty, let's get back on our track here. Physiological changes after death. Body temperature decreases. The skin isn't as elastic. You were talking about the purple discoloration of the skin. Usually with livermortis, it's the lower half of the body that turns that way, and it's the the red cell destruction that causes that modeling. Rigor mortis, that's a stiffening of the muscles after death, usually about 4 hours. Family viewing. You wash the body unless, like I was saying earlier, if the coroner has to come and do an examination, you don't want to do anything like that. But if the family's coming in, you wash the body, position them in a natural position. If family's coming in, I put the dentures back in, but when you send them down to the morgue, you take them out. And again, you talk to the family and you know, just go over what they should expect, what's going to happen next. Usually in a hospital, if a death occurs within the first 24 hours, they have to have an autopsy, or the coroner has to do an examination. So they go down to the morgue and everything is left in. You don't take anything out. Always let the family know that that's what's going to happen. Don't just do it and then tell the family later. Prepare them before they go. Organ donations. Each facility has a different policy. Know what that policy is. If you're going to be charged nurses, so that'll be a very important policy. Usually there's a donation hotline, and you'll call that, and they will actually contact the family. A lot of things depends on how you ask or what you say, whether they will allow organ donations or not. So I don't talk to the family about that. I just refer I send out the message to the donor hotline, and they contact the family. Usually you have to give them a lot of information about vital signs and medications that the patient's taking and that sort of thing, and so usually you'll have a checklist in the facility where you are, what to do. All right. Yeah, usually you have to have a trained requester to talk to the family. Transplant time frames. You have about 4 to 6 hours on the heart and lungs. Liver and pancreas, 12 to 24 hours. Kidneys, 4 to 72 hours. This gets into the nurse self-care. Then grief is a common reaction. We all go through that. We all have our favorite patients in the facilities. Take time to breathe. Even on shift, go take a break, take 15 minutes, go for a walk, do something to kind of get yourself back together, because you still have patients that you got to take care of. But just learn, take courses on death and dying. Kubler-Ross has written a lot of books on death and dying, and that's a good resource. That's all of those.
So I was gonna talk about, you were saying like take time to grieve and stuff because you have other patients.
Yes.
And I had an instant that we had a code on the medical unit, and so I was doing CPR, but I still had a patient to feed for breakfast.
Mm-hmm.
And so, we finished the code, and the patient got sent off to ICU, but I still had a patient to go feed. So I'm completely just sweating at that point. But he's like, I sit down to go feed him. He's like, so how's it going? I was like, it's going pretty good. How are you? And so you kind of have to put on a little bit of a different face to do that. But taking that time, later on, or at least communicating with your manager, saying like, hey, can someone cover my spot for a second, is a good thing. Because I had not done that, because it just like kind of gives you, whether you're emotionally involved or not, gives you a second to actually breathe, to kind of process it, and then kind of move on with the rest of your day. But I just thought it was more comical than anything, just because it was, you know, it's just life, because no one else, you know, it's just someone else's care, you know. So anyway.
It's weird because it gives you kind of an endorphin high, especially if you have a code and you're and you know you have to go and do something else. So you get done with that, and then you're on that endorphin high, so you know you got to go the next. It's like you just.
Right. It was kind of weird. I had been in a couple codes recently to that, and so at that point I was not. I didn't have the endorphin high. I was more of just kind of like just there, just doing what needed to be, what everyone else was doing, you know, and. So it was just kind of, it just more felt awkward and weird to walk out and just be like, gonna go feed my patient now. So anyway.
That's tough. I was charge nurse in a nursing home, and we had 53 patients at that time, and I had 5 crises going on all at the same time. And being a night nurse, you don't have a lot of help. We had 3 CNAs and myself. And we had 5 crises going on all at the same time, and you learn just to buck it up and do what you got to do and concentrate on that and not worry about your feelings until after it's all over with, and then you have time to grieve. But you have to concentrate and really hyper focus on just getting the job done, more task oriented than anything else. I can't find my post. I was going to go over the post, and I don't think I have access to that. Oh, what do you do?
You can pull one up on the internet, Dan.
Okay.
You can just pull up your browser and pull up a post.
All righty, let me try that. Okay. That's not. Okay. That's not going to work. That's the one. Well, that's not what I want either. Easy for you to say. Let's see. We'll do that and see if we can bring up a new. See, it's not letting me do that. Oh, no, that's email. I don't want that. That's something else. Oh, that's not what I want either.
Well, Dan's looking for that. I was going to interject real quick.
Okay, good. Thank you.
I was going to say, back to the dying thing. I know it's hard, but a happy moment, I guess I should say, is that when that kind of things happen, it's kind of nice to go help someone almost immediately after. Because especially those little old ladies or something like that in like a nursing home setting, they just want to give you the best little hugs. And it's kind of like its own little like therapy session. I would like a good thing. I was always like, yeah, let me go help people. Let me go talk, because it was like my own little venting thing.
That's a great point.
Yeah.
Dan, I have it. If you will go down to your screen share and allow multiple shares, then I can pull it up for you if you'd like.
Okay, that would be awesome. Where's that?
So if you go to your screen share and hit the screen share button, it'll say allow multiple screen shares.
Advanced files? No.
Just a little screen share button. Does it not pull it up to you?
No.
Okay, hang on just a second.
Let me look at one more spot here.
It should be like a little box with a little arrow, I think, pointing up.
There we go. I found it.
Yay. Okay. All right, let me see if I can share that for you. Oh, I was going to email it to you so you could pull it up, and so I pulled it away. Okay, let me open that really quick. All right. All right, here we go.
There it is. So, pretty self-explanatory, the first part, right? Patient's name, their suffix, Mr., Mrs., whatever they want to go by. First name, middle name, if they have a nickname, you can put that there. Their birth date, their gender, medical record number, if that's pertinent to the, like if you're in a facility, that sort of thing, you'd have a medical record number on there. Their address. In box A, it's CPR. If you're unresponsive, there's no pulse, and you're not breathing, what do you want us to do? Do you want us to start CPR, or do you not want us to start CPR? Pretty simple, A or B, or one or two. Then, if you have a pulse and still breathing, that's section B. Can we scroll down a little bit, Karen? There we go. What do you want? If you're still breathing and everything's, but they don't think that there's gonna be a whole lot of chance for you recovering. Do you want just comfort measures only? You want to do a whole lot of things. Comfort measures only is the first box. Usually you don't transfer the patient to the hospital if they have this. Pretty much just, we call it palliative care or comfort care, hospice. It's just basically taking care of the client's needs where you are. Pain, oxygenation, anything like that. Limited treatment, IV fluids, cardiac monitor, any advanced airways, mechanical ventilation. They usually don't want any of that. Sometimes we have CPAP and BiPAP that we put patients on. It's just a mask that goes over the face. It's kind of like a ventilator, but it's an assistive device rather than an actual ventilator. And so you want comfort measures only, limited, or full treatment. If you have limited treatment, down here on additional orders, down at the bottom of section B there, you'd want to write that all out. Uh-oh, what happened here? Oh, I can't operate that. Anyway, any exceptions you'd put in that additional orders part, and you can attach a addendum to the pulse if there's additional orders. Section C is who all did you talk to come up to this decision? Patient, parents, appointed person, advanced directive. If you have an advanced directive and a family member is going to be making those decisions, court-appointed guardian. If it's a person with developmental disabilities that can't sign for themselves, there's usually a staff member that's taking care of those people. Sometimes a relative or friend will be there. And you'd put down the last names of all the people that was in there and their relationship. That's not a whole lot of space, so usually you add something to it if you need to add a sheet to it. The patient has to, well, they don't have to sign it. It's better if they do. Want to print their name again. a lot of times we can't read signatures, so we went to print the name next to it, so we're sure that's the same person. If it's a family member or an appointed guardian, that sort of thing, again, we want to know who it is and put the relationship there.
Can the POA just sign this and like deal with this, or do they have to meet with like a healthcare representative to do it?
Has to be signed. This is a physician's order, so it has to be signed by an advanced practitioner, MD, osteopath, naturopath, physician's assistant, or a advanced nurse, nurse practitioner type of thing. And they have to sign it. They have to print their name. You can see that down at the bottom in section E, where it says print their name there and then sign the name below. They have to put their phone number on there. They have to put their license number on there. And they have to put a date on there that's the date that they actually talk to the family and establish that. This is a physician's order, just like if the doctor was sitting in the hospital and had the chart open and put in a physician's order. This is an order just like if they said give the patient 5 milligrams of morphine. It's just it's treated the same way.
So the social worker doesn't go over this with the patient as well?
They can. They don't have to. Usually it's the doctor and the nurse. But I know social workers have come in and gone over it with patients before. It's not isolated to just the doctors and the nurses. I know family members have come in and gone over it with the patient after it was already signed. Lots of different options there.
It's really important to note, though, that if the patient wants to change this and they want resuscitation, please don't take the doctor's order as a death sentence.
No.
Also,
if the patient or the family member, if the patient codes on you, I was on the code team at Kaiser, so this happened frequently. Patients of DNR, I mean, you have a history in your computer for years of the patients of DNR, and the family member happens to be sitting there, and this is kind of a gray area on the post and that sort of thing. But if the family member is sitting there and they say, we want you to do everything for our family member possible, then the code team has to abide by that, or they usually do. They don't have to, but that's pretty much up to the physician. But
Dan, I'm going to interject for a minute. When I did hospice care, if the family wants to change what the patient said, if the patient has had a personal conversation with their doctor, it is the doctor's responsibility to abide by what the patient said, and the family cannot override it. And there have been situations where this has been taken to court. So the physician is tied to the post form and what their interaction was with the patient. And if they, the doctors can be sued, quite honestly, if they don't follow what the patient said.
Even if the family has a power of attorney, they still can't change the post?
If the patient has power of attorney, then that is a different situation, and the patients then are not involved with this discussion per se, as far as decisions being made.
Well, I mean, like if the patient signed a post with their doctor, then they declined, and a family member assumed power of attorney, could the family then go and change the post, or is it still no?
No, the doctor needs to continue to abide by what the discussion was with the patient, because the patient is trusting that the doctor follows what their wishes are. So it needs to be in support of the patient and what their decisions were when they were of sound mind.
Yes, and that's the key word there. They had this discussion with their physician in their sound mind, meaning that there was nothing that was they weren't, didn't have dementia of any kind. So I think that I agree with what she's saying. I think the doctor has to uphold to the agreement that they made.
Right.
This
So
is why
like
we
I
do
had
directives.
Right. No, there's a lot of gray area in that because I had my own experience. I ended up, I was a home caregiver for my grandmother, and she ended up having an internal bleed and she passed out, and I started CPR. Her POA, actually, her daughter told me to start CPR, and she was actually a DNR. But once I started CPR, you can't stop.
Right.
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 So that's where there's a lot of gray area in that too.
There is, you're right. And honestly, on the pulse form, you cannot be a full code, but be comfort measures only. If you want comfort measures only, you do not need to be a do not resuscitate.
Mm-hmm.
If you are attempt CPR, then your interventions would be limited or full treatment.
Full treatment.
So you can't interchange those because it just creates more confusion.
Mm-hmm.
So, and also too, when these forms are completed, on the back side of this form, there is a pulsed registry that is through OHSU, and these forms need to be sent to that PO box, because what they do is they put it in the database so that when there is an emergency and 911 is called, they are able to pull it up on the computer and see what the patient's wishes are, so they know exactly what they're going to be doing or not doing when they enter the home setting or wherever the patient is.
So isn't there something as like a partial, not partial CPR, yeah, maybe partial CPR.
Partial code.
Yeah, so wouldn't you like just do like compressions but not ventilations, or vice versa? So how does that work?
There's medical codes, there's no shock, there's lots of different variations, and that has to be, that has to be written down by the doctor on just the specific direction that they want to go. And again, it has to be discussed with the patient or the family or whoever.
Oh, okay.
But yeah, in a code situation in a hospital, it can get very sticky because it does have a broad gray area there, and in the ultimate, in that situation, the doctor has to he has to accept responsibility for himself. So if he says continue CPR and we know that they're a DNR, we have to abide by the doctor's order at that time. If the family is saying, you know, save my mom, save my mom, save my mom, and the doctor says continue CPR, we have to do that. We can't override the physician. It gets to be very sticky there, but I hope you're never in that situation. I've been in it too many times. So yeah, I hope you're never in that situation. It can get very complicated. Sometimes you'll have the family member there that's a power of attorney, and they'll say, just let her go. She might be a full code. The POA can say, let her go. And another family member says, no, do everything you can. So you get in this back and forth. So the doctor has to be the one that makes the final decision. We as nurses don't have that. Thank goodness we don't have that responsibility.
So how does that work when you're in the home and there's no doctor around?
You have to abide by whatever the doctor's order says. Whatever your pulse says, you have to abide by that. You can't deviate from that. And a lot of times, I worked a lot of night shifts, and I had a situation where the family said, we want you to continue to do everything for my mom and send her to the hospital, et cetera, et cetera. She was a DNR, comfort measures, don't transport, et cetera, et cetera. I called the doctor in the middle of the night, and we ended up sending the patient to the hospital. But yeah, it gets really sticky if people want to override what the pulse says.
Yeah, my dad was life flighted, and he coded 3 times, and he was a DNR, but my stepmom said save him, and so the doctors went against what my dad's wishes were and resuscitated him 3 times.
Yeah, it's tough because, like I say, that's a decision the doctors have to make. It's their license on the line. It gets to be very very touchy at times. We've had a lot of situations where the family was very upset that we resuscitated somebody that was a DNR. We called the family and told them that their family member was in ICU on intubated on a ventilator, and they were very upset. Came in very irate that, yeah, it can go both ways. Main thing to know is know what your policy in your facility is. If it's your decision to make sure that you have the paperwork to back up what your decisions are. Don't do anything out of your scope of practice. If it has a physician's order on it, that's what you do. And if the family member wants to change that, you don't have the authority to change that post. I know in nursing homes a lot of times that happens, and I've had to not do CPR when family members wanted me to because I knew the patient was a DNR. And so, yeah, it puts you in a tough spot. So hopefully as you gain experience, you get out in the field and gain experience, people will share with you their experiences and give you ideas on how to handle that. But like Deborah was saying, if you have a piece of paper in your hand and you know what the code status is, until a doctor tells you differently, you have to abide by that. Fun. I hope, like I say, I was on the code team at Kaiser and have been in thousands of codes over my years, and I hope you're never in that situation. We had one situation that the patient got too much pain medicine and stopped breathing and coded, and we ended up bringing him back. And as we were moving the patient out the door, the blanket caught on the door jamb and pulled the blanket off of the patient's hand. And there was a DNR wristband on the patient. And we all looked at each other and shook our heads. And the nurse was standing right there saying, you know, she's the one that started CPR. And the code team arrived, and we continued and resuscitated the patient. But it was like, now what do we do? And of course, the doctor wasn't very happy because he has to call the family and all of that. But yeah, so that's going to be your critical decision-making, critical thinking processes once you get out into the field. And hopefully you have a lot of experience before you have to deal with one of those. Question came up for the next Zoom meeting, use the same login and everything. Yes, it's the same site. Alrighty.
Did you
Dan?
want to ask one more question before you get off?
I've got a question. I won't be able to make the next Zoom. It's my dad's funeral. Where do I go? Will this be uploaded to my IoT so I can watch the next Zoom and take notes?
Either that, or we'll send out an email with the. I got to get with Karen and figure out how to do that. Yeah,
I'm so sorry for you, Beth. So sorry.
Hey, Beth. I know that you hear a lot of "I'm sorry" and there's no words to ever describe what you're going through, but just know, like, I don't know you, but if you need anything, if you need to vent, I'm a phone call away. You know, I hope that God gives you and your family the strength you need to overcome this pain. You got this, girl. You know, I can only imagine how it feels going through nursing school and losing someone you love, but you got this. Like, you have people that care for you, and you know, like I said, I don't know you, but I'm pretty sure that many of us will open our door for you. If you need anything, please don't hesitate to ask. Even if you need to call at 1, 2 in the morning, I don't care. You know, you could always call and just vent.
You're Beth. That's pretty hard. I don't know what I would do if I lost my dad. So
he was my person.
Yeah. Yeah.
Thank you, guys.
Yeah.
We love you, Beth. You know that.
Considering you're getting a 47-person group hug.
Yes.
Yeah, for sure.
Absolutely.
Hey, she deserves it.
You're an awesome group.
Yeah.
It's amazing that you're even here this morning. So thank you.
Okay, now y'all are making me cry. We got.
Yeah, me too.
So, on a side note, not to take away from Beth, I'm sorry, honey.
Oh.
If we attended this Zoom, we do need to attend the other Zoom. It's not the same content, like stuff that we're going to go over, right?
Correct. We're going to just go through some VSIM stuff, just to kind of help you guys through a little bit more of that. That's kind of the intent for this afternoon. We need to give you at least 6 hours to make up for not being able to be in school today. We have 5 hours of Zooms planned and 2 hours of homework that you can do additionally. So if you can't make all of that, or if you can't be here this afternoon, or if you can't watch the recorded ones, we will have to find something else for you to do to make up those hours. But they are at least available to you.
So I have a quick question. So the timesheet for this week is to do the what's that guy?
Vernon Russell.
Yes, but then it's also our final grade. So we're just for what I have heard on the chat, like, we are a little bit confused. So it said do this Sunday, or it said do on the 10th week.
What we did with that was allowed you 2 weeks, just like the last one, because this has been sort of, you've been the guinea pigs. We've been interrupted in our class times. You know, it's been very challenging and not fair to you. No. So we have given you the 2 weeks to get that in. So even though you have homework week 8 and homework week 9, they are both due at the same time. So you do have a little time to work on it.
It's due the Sunday of week 9.
So the 15th.
I'd have to look at a calendar. Is that right, Lori?
And I see there's a question here regarding Sean's. Now, Sean told me that he did 103 yesterday.
He's going to do a Skype or a VSIM Zoom. I think he's going to do it at 1 o'clock today as well.
He said he was doing 203 and 303 today, so maybe he's just inviting everybody to come regardless. So
yeah, you should.
We can go to either.
If you go to that, just make sure that you record your time and take notes, and upload a. Oh, I don't know how we're going to do this. Somehow I've got to get your time. Somehow I've got to get your time on a timesheet. So write it down, do something, give me some sort of, I don't know if you guys have the blank timesheets.
We don't. Can you email them to us and we can fill them out and upload them?
You can just add it to your virtual timesheet and just explain which one you went to. But yes, Sean's is at 1. I don't know how long he plans to be on. Ours is from 12 until 3-ish, so that we can give you as many hours as we can. But it sounds like we're basically going to be talking about the same thing, VSIM.
Does this time that we're on now, is this time that we're recording, do we still have to write this down, or?
Oh, yes,
are we
write your
accounted
Zoom
for?
into your virtual time.
Yeah, write it on your timesheet.
Yeah, put it in your timesheet. So 9 to 11.
And someone's gonna send us a blank timesheet.
Just put it on the virtual timesheet for that week. Just handwrite it in.
So for week 8.
Yeah, so
Yeah.
your week 8 timesheet, just add it to your virtual. And if you do the reading, do the same thing, add it to your virtual timesheet.
And can
Week 8 and week 9, both of these weeks. And I was saying earlier, we're working on developing communication with the computer at work, and so I'm going to try to get the timesheets all done today. So don't freak out if your grade and your time isn't on that on my IoT yet. I'll have that done today or tomorrow.
And next week, we're not absolutely sure if we will be still doing Zooms or if they'll let us on campus. So we'll let you know as soon as we know.
Could they get Sean to take attendance at the Zoom maybe? And that way, all they have to do is put the date and the time and he'll verify the attendance.
Yeah. I'll email him and have him send me a list of attendees.
Okay.
So as to the question about whether to turn in your timesheet, it probably wouldn't be a bad idea. Just make a duplicate, just so that you know that you're covered.
So according to Kaylee, we're down next Thursday as well. We're not coming back until Friday.
Okay. Since technically our 10 days is up on Sunday or Monday,
it's 14.
Oh, 14 they want now. Okay.
Yeah, 14 days from the time that we were exposed, which was last Thursday.
Okay.
Anyway, that's what I understood from Kaylee anyway. Bonnie said the same thing, that we wouldn't be back until the Friday.
So I understand some of you work in the afternoons. So would you prefer that we do a 9 to noon or 8 to 11 and a 12 to 2? Would there be some better hours in order to help you out? Well, Elise works in the mornings.
I know for me, 9 to noon, I have to work in Albany at 2:30. I have to be there by 2:30. Usually when I leave on Thursdays, I head straight there. So, yeah.
You just have your computer hitch a ride in the passenger seat.
True that. I can do it on my phone, I guess.
Well, we'll have to adjust. We do have some evening classes here, so we'll have to adjust. We'll talk about that after we're done here and see if we can do a later time for the evening shift. We still haven't been able to get Becky on the Zoom meeting, so I'm going to work on that today. We're having trouble getting the internet connection and the Zoom connection to Becky, so she wasn't able to get on this morning, but hopefully we can get that solved by the afternoon.
Dan?
Yeah.
Just a clarification. I know everybody is continuing to work, but everyone, we were all, the names were given to the health department, and so that we have had an exposure, and so that I don't know, clarifying wise, if that is that everybody understands they've had an exposure as far as the health department is concerned, and that they need to act accordingly for their work, et cetera, et cetera. So
I would need to tell my job that we've been exposed.
Wait, what? So
no, so I'm saying that we need a clarification on that.
Yeah.
Yeah, she'd need to talk to Kaylee.
Please do, yeah.
Yeah, so what I'll do is but just, you know, I didn't even, but Kaylee talked about all the names that she had to send to the health department. So I'll talk to Kaylee and have her send out a general clarification on that as far
For
as
the
what
evening shift,
you're reporting to work.
So is the health
Right.
department all our work?
No, they might call you.
Oh, okay, because I told my work and she was like, you could be exposed walking on the street, so you just have to
monitor,
monitor, and then monitor, and then if you have any symptoms, then you get tested. But other than that, you still come to work.
That's what they do at the hospital.
Yeah.
They're
Okay.
just like, self-monitor.
Okay.
So-
I'm just curious about that one thing. That's all.
Kaylee was going to send out a notice to all the students that were involved in that class.
I have yet to hear back from either the health department or the school.
I thought we were going to be notified by Wednesday morning if we had been exposed.
Again, I'm going to have to refer that to Kaylee. She's the one that does all of that. So
I think if you guys were exposed, you have already been told. So if you haven't been told, I think
okay.
Yeah, I've been told.
That's what I read too.
We got a phone call.
Yeah.
Okay.
Yeah, Kaylee was going to call everybody that was in the class that was exposed.
Okay.
I got a call from Tim.
Evening group.
Alrighty.
Sweet. Good clarification. Thank you.
Alrighty. Looks like we're approaching the 11 o'clock mark.
So again, do we just attend the Zoom again at the 12 o'clock time?
Yeah.
12 o'clock if you want to get some more hours.
Okay.
And I think for evening class, we're going to have to start earlier if we do this again next week. So we'll have to start earlier next week for the evening class.
All right.
And they will be recorded, so you can watch them at your own time. We'll get that out to everybody, the link. We'll get it out to everybody, so you'll have access to the recorded Zooms. The final question for those that are going to be watching this is, what's the name of my little doggie? Her name is Abby.
What's your dog's name?
Abby.
Abby. Okay.
Yeah, I'd bring her in, but she's a little hyper right now. So she's out in the front room running all over the place because I'm locked up in here.
So we should just list these hours at the bottom of our timesheet then?
Yes. Just write Zoom and 9 to 11.
Is that
2 hours.
addition to the reading you guys want us to do, the 2-hour allotment for that?
No,
Like
the reading is on top of, you get credit for that as well.
Okay, so put that at the bottom of the timesheet too.
Right, you can write that in also.
Okay.
What was the extra chapter you wanted us to do?
92.
92.
Thank you, Jonathan.
Is it just chapter? Sorry, I didn't mean to cut somebody off.
Okay. I was just if Dan was going to upload on IoT the PowerPoint that he wanted.
Yeah.
I will do that here shortly.
Thank you.
Thank you.
So was it just chapter 92, or were we supposed to do the learning objectives or take notes?
You just answer the learning objectives.
Okay.
Then we just put that at the bottom of week 8.
Yes.
Okay.
You want the cardiac PowerPoint and the end of life both?
End of life is already on e-supplement, I do
Yeah.
believe. But the
Yeah,
cardiac,
that's on there, just the cardiac.
Okay. All righty. I
Thank
will
you.
put that on there.
Thank you. All right. Thank you, Tim.
Thanks everybody for being here.
Yep.
Thank you.
Thank you.
I thank you.
I have a question. I missed talking about it because my kids were fighting. But the if we got the call and then if we got the email, do we wait until we get a call from the health department to like go to work or anything, or can we because I told my work and they COVID tested me. They did a rapid test and it came back negative, but they sent one to a lab. So can I go back to work once that one comes back, or?
Katie, you should call the health department and talk to them.
Really?
I was told by the health department that it doesn't matter that I was COVID tested with a rapid COVID test, and that it was negative, and that I was still to self-quarantine until I heard from the health department for further orders.
Seriously? This is...
Yeah, mine too. I got sent home today for work. I got contacted by a health department today, so I have to quarantine.
Oh, you did?
Yep.
I never got contacted by the health department. I got contacted by Tim.
No,
Yeah,
the health department sent, someone said that my name is on the list on the health department. I should recommend 14 days. So
yeah. So that's
sent me home,
if you get contacted by the health department, then you deal with that, whatever they want you to do. But Kaylee should have sent you, or Tim, or somebody should have sent you what you need to do as far as the school goes.
They literally just sent us the email saying we were possibly exposed, and then we all got calls, and then told that
From
like
the health department?
No, from Tim, and then told us that the health department would probably would contact us.
Okay.
And then, like, it's been a few days and nothing. So we just like can't do anything until we figure out what the health department wants us to do, or.
What was the message from Kaylee? Did she say self-quarantine or?
I don't think we got one. I don't know. I'd have to check my email.
What did Tim say? That just you had exposed and the health authority would be contacting you?
Yeah, and so that we'd have to quarantine. And because I asked, because my kids go to Head Start, and one of the questions is, has the adult or the kids possibly been exposed? And so I specifically asked about that question, and he said that, yeah, all of us would have to self-quarantine. Yeah.
So it's kind of confusing because I was exposed last Thursday. I was in close proximity, and I called my doctor. I've been tested since then, and it was negative. And they told me to come on in and have my procedure done, and don't worry about it. You know, you don't have to self-quarantine, etc. So it's really confusing on which authority tells you what.
Yeah.
I got an email from Kaylee today.
Department at all.
You could probably stop recording if you want at this point.
Thank you.